Hey everyone, and welcome to today's Explainer. We're diving right into a topic that affects literally millions of us, but is honestly surrounded by so much confusion and misinformation. We're talking about the intersection of birth control and body weight. We're going to break down some brand new clinical guidance together, strip away the stigma, and separate the myths from the facts. So let's start with a huge, highly searched question. Does your body weight actually dictate your birth control options? It's a massive source of anxiety, right? Just stepping on a scale at a clinic can instantly make you wonder if your size is going to somehow limit your reproductive choices. Well, today we're going to see how updated medical science actually completely challenges those assumptions. And we aren't just guessing here. Our answers today come straight from the newly revised evidence-based guidelines from the Society of Family Planning. This isn't just some opinion piece you'd find online. It's a definitive, peer-reviewed committee statement specifically designed to destigmatize contraceptive care across all body weights. By anchoring our explanation in this rigorous clinical document, we can ditch the fiction and focus purely on person-centered healthcare. Here is our quick roadmap for today. First, we'll be rethinking BMI and stigma. Second, weight and contraceptive efficacy. Third, the truth about weight gain. And finally, navigating modern weight management. All right, Section 1, rethinking BMI and stigma. So it turns out the body mass index, or BMI, has some pretty critical limitations. For decades, BMI has been treated as this ultimate proxy for health, but the Society of Family Planning explicitly calls out why that is totally flawed. It was originally developed as an indirect population-level tool based entirely on historical measurements of white European men from centuries ago. It was actually never intended to predict an individual's health. It completely fails to differentiate between muscle, bone, fat, or your organs. Simply put, body weight and BMI classifications are just not direct indicators of a person's overall health or worth. To fix this disconnect, healthcare providers are now being strongly urged to adopt weight-inclusive clinical practices. This is all about building trust and stopping care avoidance. It means using person-first language, like saying people with higher body weights, focusing on treating the actual condition rather than the weight, and crucially, always asking permission before even discussing weight. But it's also a physical thing. Clinics need accommodating waiting room chairs, adjustable exam tables, larger blood pressure cuffs, and appropriately sized equipment like longer speculums for IUD placements. It's about creating an environment where patients are treated as a real person, not just a number on a chart. Moving on to Section 2, weight and contraceptive efficacy. Now, the data here is incredibly empowering. When looking at medical eligibility for individuals with a BMI of 30 or higher, almost everything is a level 1 classification. What does that mean? It means there is absolutely no restriction on using that method. The copper IUD, hormonal IUDs, the contraceptive implant, progestin-only pills, and the depot shot, all perfectly safe and highly effective. Even combined hormonal contraceptives sit at a level 2, meaning the advantages generally far outweigh any theoretical risks. The huge takeaway here is that absolutely no contraceptive method is entirely off-limits based on weight alone. There is a little bit of nuance, though, especially when comparing specific methods like the transdermal patch versus the subdermal implant. For the patch, there is evidence of potentially decreased effectiveness and a higher risk of blood clots for individuals with a BMI over 30. In fact, the FDA label actually contraindicates the patch for individuals weighing over 90 kilograms, or about 198 pounds. Now, contrast that with the implant, which remains highly effective regardless of BMI. While the concentration of the hormone in the blood might be slightly lower in larger bodies, it remains consistently high enough to suppress ovulation and prevent pregnancy across all body sizes. It's a real workhorse. And looking at peer-reviewed data from journals like Contraception, we do see a few other minor caveats. With combined oral contraceptive pills or oral emergency morning-after pills, there might be very slight drops in efficacy as body weight increases. The reductions are really minimal, but it does highlight why having a backup like a copper IUD might be worth discussing with a doctor for emergency situations. All right, Section 3, the truth about weight gain. We're getting to the big one here. The crucial point is that the vast majority of these methods are simply not linked to clinically significant weight gain. Not the copper IUD, not the hormonal IUD, not the implant, nor combined or progestin-only pills. Human adults generally gain about 1 kilogram, so just over 2 pounds per year, as a completely normal part of aging and lifestyle factors. Because people often start birth control and stay on it for years, it's super easy to blame the contraception for normal bodily changes. But high-quality evidence simply does not support the idea that these methods cause significant weight gain. There is one singular exception in the data, though, and it's super important to uncover. The DMPA, which most of us know as the depot shot, is the only contraceptive method with a proven association with weight gain in a subset of users. Studies show this is particularly true for adolescents and individuals who already have a higher baseline BMI when they first get the shot. Now, most adolescents won't see excessive weight gain on depot, but a specific subset can gain more than 10% of their baseline body weight. So if that's a major personal concern for you, this is absolutely vital information for your shared decision-making process with your doctor. Finally, Section 4, Navigating Modern Weight Management. For anyone undergoing bariatric surgery, medical guidelines strongly recommend avoiding pregnancy for 12 to 18 months post-surgery. That's because the rapid weight loss can cause severe complications for a pregnancy. But here's the catch. Certain malabsorptive surgeries, like the Roux-en-Y gastric bypass or biliopancreatic diversion, fundamentally rewire your digestive tract. This means your body might not properly absorb oral birth control pills anymore, leading to unexpected contraceptive failure. Because of this, non-oral methods, like IUDs or implants, are heavily recommended to make sure you stay fully protected. There's also some really cutting-edge guidance on GLP-1 and dual-mechanism drugs like tirzepatide, which are incredibly popular right now for weight management and diabetes. Because these medications delay gastric emptying, literally slowing down how fast your stomach empties, they can actually mess with how oral birth control pills are absorbed into your bloodstream. The official protocol states that if a patient is on an oral contraceptive and either starts tirzepatide or bumps up their dosage, they need to use a backup birth control method, like condoms, for 4 full weeks. Or, alternatively, they can just switch to a non-oral method entirely. And get this, there's a fascinating fertility curveball here. The guidelines highlight that GLP-1 agonists can actually restore menstrual regularity. For patients dealing with conditions like polycystic ovary syndrome, or PCOS, taking these medications can significantly increase spontaneous pregnancy rates. That means, just as someone might be experiencing potential absorption issues with their oral birth control pill, their baseline fertility might actually be skyrocketing. It really makes having an effective, reliable contraceptive plan more vital than ever before. So, what does this all mean for us? We've seen that BMI is a seriously flawed metric, that almost all birth control methods are completely safe regardless of size, and that the dreaded weight gain myth is mostly just that, a myth. Discovering this hard evidence straight from the Society of Family Planning means you can walk into a clinic fully equipped to ask the right questions and demand care that truly works for you. Thanks for exploring this explainer with me today, and keep asking those great questions.